This is Kathy Knipfer, instructor for Nursing 2203, recording the Pediatric lecture for Chapter 41, Gastrointestinal Dysfunction. Nutritional disorders include vitamin imbalances, mineral imbalances, and other disorders of malnutrition. There are certain diseases and problems that increase the risk for growth failure. They are cancer, human immunodeficiency virus, sickle cell disease, cystic fibrosis, and low birth weight. Nurses should base their care on standardized growth charts as well as recommendations for dietary reference intakes, DRIs. We also should be aware of recommendations from the World Health Organization and the Centers for Disease Control and Prevention. The World Health Organization, or WHO, encourages that breastfeeding continue for the first 6 months, preferably for the first year. Protein energy malnutrition, or PEM, is described as severe childhood undernutrition. It is a significant problem in developing countries. Kwashiorkor is a deficiency of protein with an adequate supply of calories. Marasmus is general malnutrition of both calories and proteins. In the United States, milder forms of PEM occur. Ready-to-feed therapeutic food may be useful in developing countries where water may be contaminated. An allergy is a specific immune response by the individual when they are exposed to a given food. Intolerance is a situation in which a food elicits an adverse reaction without an immunologic mechanism. An example would be lactose intolerance. Clinical manifestations of food allergy may be systemic. An example would be anaphylaxis. Symptoms that might be associated with a food allergy in the GI tract would be abdominal pain and diarrhea. Respiratory symptoms could include cough or a wheeze, and then cutaneous symptoms may be atopic dermatitis. Manifestations of gastrointestinal dysfunction include growth failure, spitting up or regurgitation, nausea, vomiting, diarrhea, and constipation, abdominal pain, distension, GI bleeding, jaundice, dysphagia, dysfunctional swallowing, also fever that is usually associated with dehydration, infection, or inflammation. Dehydration occurs whenever total output of fluid exceeds intake. The causes include insensible fluid loss, increased renal excretion, GI tract dysfunction and the associated vomiting and diarrhea, ketoacidosis, and burns. Types of dehydration include isotonic, where water and salt are lost in equal amounts. This is the primary form of dehydration in children. With hypotonic dehydration, the electrolyte deficit exceeds the water deficit. With hypertonic dehydration, the water loss exceeds the electrolyte loss. Accurate measurement of INO is important. This would include urine, stools, vomitus, sweating. Vital signs, skin turgor, and mucous membranes can indicate the degree of dehydration. Body weight is an important determinant of the extent of dehydration. The fontanelles in the infant should be assessed. If they're sunken, that can indicate dehydration. Also, assess for sensory alterations. Acute diarrhea is the leading cause of illness in children less than the age of 5. Of all deaths in developing countries, 24% are related to diarrhea and dehydration. Diarrheal disturbances have several forms. There's gastroenteritis, which involves the stomach and intestines, enteritis, which involves the small intestine, colitis, which involves the colon, and then enterocolitis, which involves the colon and intestines. The types of diarrhea include acute infectious or infectious gastroenteritis, chronic intractable diarrhea of infancy, and chronic nonspecific diarrhea, CNSD. Diarrhea can be caused by viruses and bacteria. Examples would be the rotavirus, Salmonella, Shigella, Giardia, Cryptosporidium, and Clostridium. Diarrhea can also be caused by the effects of antibiotics. Therapeutic management of diarrhea includes assessment of fluid and electrolyte imbalance. It involves rehydration, either orally or intravenously. Fluid therapy would be maintained and an adequate diet would be reintroduced. To prevent diarrhea, 2 rotavirus vaccines are available. We would also want to teach personal hygiene and the importance of having a clean water supply and protecting water from contamination. We would teach careful food preparation and encourage hand washing. Constipation is an alteration in the frequency, consistency, or ease of passage of stool. It may be secondary to other disorders. There is no known cause for idiopathic or functional constipation. Chronic constipation may be due to environmental or psychosocial factors. A child who has experienced discomfort during bowel movements may deliberately try to withhold stool. This leads to the accumulation of stool in the rectum. Constipation during the newborn period. The first meconium should be passed within 24 to 36 hours of birth. If not, the nurse should assess for intestinal atresia, stenosis, Hirschsprung disease, hypothyroidism, meconium plug, or meconium ileus, which would indicate possibly cystic fibrosis. Constipation during infancy is often related to diet. It is almost unknown in exclusively breastfed infants, although the stool may become infrequent because of minimal residue from digested breast milk. Constipation may develop in formula-fed infants. Nursing interventions include assessing bowel habits, medications, diet, and stool characteristics. Lactulose and glycerin suppositories may be given. Constipation during childhood is often due to environmental changes or control over body functions. An example would be the withholding of stool. Encopresis is inappropriate passage of feces, often with soiling. Constipation may also result from stress. When managing constipation of a pediatric patient, the nurse should take a history of bowel patterns, assess medications and diet. A major responsibility of the nurse is to educate parents and the child about appropriate dietary modifications. More aggressive management may be necessary if the problem persists. Hirschsprung disease is a congenital anomaly, also called congenital aganglionic megacolon. It involves the absence of ganglion cells in the colon. It leads to inadequate motility of the intestine and mechanical obstruction. The incidence is 1 per 5,000 live births. It is more common in boys and in children with Down syndrome. In Hirschsprung disease, the aganglionic segment usually includes the rectum and the proximal colon. It involves accumulation of stool with distension. The internal anal sphincter fails to relax, and there is a potential for enterocolitis. Most cases of Hirschsprung disease are diagnosed in the first few months of life. It requires a complete and careful history, along with x-rays and barium enema studies. There may be an anorectal manometric examination. A rectal biopsy confirms the diagnosis. Therapeutic management of Hirschsprung disease requires surgery. This may be done in 2 stages with a temporary ostomy. If it's caught early with minimal bowel distension, there may be only 1 stage. Preoperative nursing care may involve saline enemas and antibiotic administration to decrease the bacterial flora. Skin and stomal care is a major nursing task during the postoperative period. Before discharge, parents and possibly the child need instruction concerning colostomy care and the establishment of a bowel training program. Vomiting is the forceful ejection of gastric contents through the mouth. It is often accompanied by nausea. It is common in childhood and is usually self-limiting and requires no special treatment. You would want to look for acute fluid volume loss, as you would see in dehydration and electrolyte disturbances. Management of vomiting is directed toward detection and treatment of the cause of the vomiting and preventing those complications, such as fluid imbalances. The nurse should take measures to reduce the vomiting and accurately assess the type of vomiting and the appearance of the vomitus and associated child behaviors. If the vomiting is believed to be an indication of obstruction, food is usually withheld and special feeding techniques are implemented. Efforts are primarily directed toward maintaining hydration or preventing dehydration. The vomiting infant or child is positioned on the side or semi-reclined. Gastroesophageal reflux, or GER, is the transfer of gastric contents into the esophagus. It occurs in everyone. GERD represents symptoms or tissue damage that results from GER. GERD stands for Gastroesophageal Reflux Disease. GER may occur without GER disease or GERD. GER disease or GERD may occur without regurgitation. Approximately 50% of infants younger than 2 months old are reported to have GER. It usually resolves spontaneously by 1 year of age. The causative mechanism likely involves inappropriate transient relaxation of the lower esophageal sphincter. The history and physical examination are usually sufficient to diagnose. An upper GI series is often helpful in diagnosing GER. The 24-hour intraesophageal pH monitoring study is the gold standard in the diagnosis of GER. Surgical management of GER is reserved for children with severe complications. H2 antagonists and proton pump inhibitors may be administered to reduce gastric hydrochloric acid secretion. Nissen fundoplication is the surgical procedure used to treat GER. Nursing care involves teaching. The nurse should teach about feeding and positioning, medication administration, foods to avoid such as spicy foods, and what to avoid when breastfeeding, such as specific foods. This is a picture of the Nissen fundoplication where the sutures pass through the esophageal musculature. Intestinal parasitic diseases are the most frequent infections in the world. In humans, they are caused by a variety of organisms. The two most common in the United States are giardiasis, which is caused by a protozoa, and pinworms, or enterobiasis, which is caused by a nematode. Acute appendicitis is inflammation of the vermiform appendix. Appendicitis is caused by obstruction of the lumen of the appendix. That is usually by hardened fecal material. Also, swollen lymphoid tissue or even parasites can obstruct the lumen. With acute obstruction, pressure builds up, and this results in compression of blood vessels and ischemia. Ulceration occurs along with bacterial invasion. Necrosis causes perforation or rupture with fecal and bacterial contamination of the peritoneal cavity. Clinical manifestations of appendicitis include right lower quadrant abdominal pain, fever, rigid abdomen, decreased or absent bowel sounds, vomiting, possibly constipation or diarrhea, anorexia, tachycardia, rapid shallow breathing, pallor, lethargy, irritability, and stooped posture. McBurney point may be the most intense site of pain. Treatment of appendicitis before perforation includes rehydration, antibiotics, and surgical removal of the appendix, and this may be done laparoscopically. For ruptured appendix, there may be IV administration of fluid and electrolytes, systemic antibiotics, and nasogastric decompression. Complications are uncommon after a simple appendectomy. Postoperatively, listening for bowel sounds and observing for other signs of bowel activity are a part of the routine assessment. Wound and skin care and administration of antibiotics would be an important part of postoperative care. Meckel diverticulum is a remnant of the fetal mesenteric duct. It is the most common congenital malformation of the GI tract. It occurs in 2 to 4% of the population. It involves ulceration, bleeding, and intestinal obstruction. Meckel diverticulum is diagnosed through radionucleotide scintigraphy. Treatment involves surgical removal of the diverticulum. If it is diagnosed early and treated, one can expect a full recovery. Inflammatory bowel diseases, or IBD, include ulcerative colitis and Crohn's disease. There is a genetic influence, and there are theories about defective immunoregulation. The inflammation found with ulcerative colitis is limited to the colon and rectum. The chronic inflammatory process of Crohn's disease involves any part of the GI tract from the mouth to the anus. It involves all layers of the bowel wall. The diagnosis of ulcerative colitis and Crohn's disease comes from the history, physical examination, laboratory evaluation, and other diagnostic procedures. Stools are examined for blood, leukocytes, and infectious organisms. These patients may also undergo upper endoscopy and colonoscopy with biopsies. Common medications include 5-aminosalicylates, corticosteroids, immunomodulators, and possibly antibiotics. Nutritional support is important in the treatment of patients with IBD. Growth failure is a common serious complication. The goals of nutritional support include correction of nutrient deficits and replacement of ongoing losses, provision of adequate energy and protein for healing, and provision of adequate nutrients to promote normal growth. Surgery may be required when complications cannot be controlled. IBD is a chronic disease. The outcome is influenced by the regions and severity of the involvement and appropriate therapeutic management. The development of colorectal cancer is a long-term complication of IBD. Peptic ulcer disease, or The overall PUD, prognosis for may be an ulcerative acute or colitis chronic is good. condition. The exact cause is unknown, although infectious, genetic, and environmental factors are important. There is a significant relationship between the bacterium Helicobacter pylori and ulcers. Ulcerogenic drugs, alcohol, and smoking contribute to ulcer formation. Psychological factors may play a role in the development of PUD, along with stressful life events, dependency, passiveness, and hostility. For diagnosis, the focus is on taking a history of symptoms, physical examination, and diagnostic testing. The symptoms to look for might be epigastric abdominal pain, nocturnal pain, oral regurgitation, heartburn, weight loss, hematemesis. NSAIDs and corticosteroids may potentially also cause the problem. An endoscopy of the esophagus, stomach, and duodenum is the most reliable procedure to diagnose PUD. A biopsy can determine the presence of the H. pylori. A blood test can also identify the presence of the antigen to this organism. PUD may be treated with antacids, PPIs, and antibiotics for the H. pylori. Surgery may be required for complications such as hemorrhage, perforation, or obstruction. The long-term prognosis for PUD is variable. Many are successfully treated with medical therapy, and some do recur. Hepatitis is an acute or chronic inflammation of the liver. It can be viral, non-viral, autoimmune, metabolic, hemodynamic, or idiopathic. Types of hepatitis include hepatitis A, B, C, D, E, as well as G. The hepatitis A virus is spread directly or indirectly by the fecal-oral route, by ingestion of contaminated food, direct exposure to infected fecal material, or close contact with an infected person. Hepatitis B can be an acute or chronic infection, ranging from an asymptomatic limited infection to a fatal, fulminant, or rapid and severe hepatitis. Humans are the main source of infection for HBV. HBV may be transmitted parenterally, percutaneously, or transmucosally. Most HBV or hepatitis B infections in children is acquired perinatally. Perinatal infection occurs during the birthing process when the infant comes in contact with maternal body fluids, most likely blood. Infants and children who are not infected during the perinatal period remain at high risk for acquiring person-to-person transmission from their mothers during the first 5 years of life. The hepatitis C virus is transmitted parenterally through exposure to blood and blood products from HCV or hepatitis C infected people. The most common risk factors are injections, drug use, having received a blood product before 1992, and having multiple sex partners. Refer to Table 41-10 on page 1284 for a comparison of types A, B, and C hepatitis. Pathologic changes occur primarily in the parenchymal cells of the liver and result in variable degrees of swelling, infiltration, degeneration, necrosis, and fibrosis. These changes may alter liver function. The disorder may be self-limiting with regeneration of liver cells without scarring, leading to a complete recovery. Some forms of hepatitis do not result in a complete return of liver function. Diagnosis is based on the history, physical examination, and serologic markers for hepatitis A, B, and C. The goals of management of hepatitis in children include early detection, prevention of further viral replication, support, and monitoring the disease. A number of antiviral medications are being used to treat HBV and HCV. Proper hand washing and standard precautions prevent the spread of viral hepatitis. Prophylactic use of standard immunoglobulin is effective in preventing hepatitis A in situations of pre-exposure. Hepatitis B immunoglobulin is effective in preventing HBV infection after one-time exposures such as accidental needle punctures or other contact. Vaccines have been developed to prevent HIV and HBV. The HBV vaccination is recommended for all newborns and for high-risk groups. The HAV vaccination is recommended for infants starting at 12 months of age. The prognosis for children with hepatitis varies and depends on the type of virus and the child's age and immunocompetence. The nurse can explain medical therapies and infection control measures. The nurse should also encourage a well-balanced diet, a schedule of rest and activity adjusted at the end stage of many chronic liver diseases. It is very important for the nurse to teach it can
about
also result from infectious, autoimmune, or toxic factors and from chronic diseases such as hemophilia and cystic fibrosis. A cirrhotic liver is irreversibly damaged. Clinical manifestations of cirrhosis include jaundice, poor growth, anorexia, muscle weakness, and lethargy. Ascites, edema, GI bleeding, anemia, and abdominal pain may also be present. There is no successful treatment to arrest the progression of cirrhosis. The goals would be to monitor liver function and manage specific complications such as esophageal varices or malnutrition. Liver transplantation has improved the prognosis substantially for many children with cirrhosis. Biliary atresia is also called extrahepatic biliary atresia. This is an inflammatory process that leads to bile duct fibrosis and eventually leads to blockage. The exact cause is unknown. Clinical manifestations include jaundice, dark urine, white or tan stools, hepatomegaly, splenomegaly, poor fat metabolism, poor weight gain, generally growth failure. Pruritus and irritability are also common. The primary treatment is surgery. Medical management is primarily supportive. It includes nutritional support, also supplementation with fat-soluble vitamins, multivitamins, minerals such as iron, zinc, selenium. The patient might receive continuous gastrostomy feedings or TPN. Long-term survival has been reported in children who have the surgery. However, even with successful bile drainage, many children ultimately develop liver failure. So if it is left untreated, it results in cirrhosis. So early diagnosis is important. A liver transplant may be an option. Cleft lip and cleft palate are facial malformations that occur during embryonic development. They may appear separately or together. They may be caused by a combination of genetic and environmental factors. These malformations are discovered through visual examination. The severity of the cleft palate has an impact on feeding because the infant is not able to create suction in the oral cavity that is necessary to feed. Closure of the lip defect precedes correction of the palate. It is performed when patients are 2 to 3 months of age. Procedures that are used are the Z-plasty, which minimizes retraction of the scar, and also the Millard rotational advancement technique. Specific methods are available to protect the suture line. Surgical correction of a cleft palate typically is performed when the patient is 6 to 12 months of age. The timing of this procedure may have an effect on speech development, so a speech-language pathologist may be consulted. Growth failure in infants with cleft lip and palate have been attributed to preoperative feeding difficulties. Cleft lip may interfere with an infant's ability to achieve an adequate anterior lip suction. An infant with an isolated cleft lip typically has no difficulty breastfeeding. Cleft palate reduces the infant's ability to suck. This interferes with breastfeeding and traditional bottle feeding. Modifications to positioning, bottle selection, and feeder supportive techniques can help infants with cleft palate feed efficiently. Infants with clefts tend to swallow excessive air during feeding. Thus, it is important to pause during feedings and burp the infant. During the postoperative period, major efforts are directed toward protecting the operative site. A syringe may be used for feeding for 7 to 10 days after the procedure. An upright or infant seat position is helpful. Avoid the use of suction or other objects in the mouth, such as tongue depressors, thermometers, pacifiers, spoons, or straws. Esophageal atresia is the failure of the esophagus to develop as a continuous passage. TEF, or tracheoesophageal fistula, is the failure of the trachea to separate into a distinct structure. These may occur separately or in combination, and the cause is unknown. The diagnosis is established on the basis of clinical signs and symptoms. The exact type of the anomaly is determined by radiographic studies. The 3 C's of tracheoesophageal fistula are coughing, choking, and cyanosis. Other manifestations include excessive salivation and drooling, apnea, increased respiratory distress during and after feeding, and abdominal distension. Management of TEF includes maintenance of a patent airway, prevention of pneumonia, gastric or blind pouch decompression, supportive therapy, surgical repair. The prognosis is good in an otherwise healthy child. Hernias are protrusions of a portion of an organ through an abnormal opening. There is a danger of incarceration and strangulation. Types of hernias include diaphragmatic, those on the abdominal wall, and those in the inguinal canal. Hypertrophic pyloric stenosis is a constriction of the pyloric sphincter with obstruction of the gastric outlet. Over time, inflammation and edema further reduce the size of the opening. This results in complete obstruction. The standard therapy for this disorder is surgery. The procedure is called a pyloromyotomy. This procedure is often performed laparoscopically. Before surgery, the infant must be rehydrated and the metabolic alkalosis must be corrected with parenteral fluid and electrolyte administration. If there is no evidence of fluid and electrolyte imbalance, surgery should be performed without delay. Feedings are usually begun 3 to 6 hours after surgery. Feedings begin with small, frequent feedings of an electrolyte solution such as Pedialyte or sterile water. Formula or breastfeedings are initiated if clear fluids are retained. The amount and the interval between feedings are gradually increased until a full feeding schedule is reinstated. This usually takes about 24 to 48 hours. Most infants recover completely and rapidly after the surgical obstruction that occurs with hypertrophic pyloric stenosis. Intussusception is a telescoping or invagination of one portion of the intestine into another. It is the most common cause of intestinal obstruction in children aged 3 months to 3 years. It is occasionally due to intestinal lesions. The cause is often unknown. Here is a diagram of intussusception. Intussusception occurs when a proximal segment of the bowel invaginates into the distal segment, pulling the mesentery with it. The mesentery is compressed and angled, resulting in lymphatic and venous obstruction. As edema increases, pressure increases. When pressure equals the arterial pressure, arterial blood flow stops. This results in ischemia and the pouring of mucus into the intestine. The classic triad of intussusception symptoms are abdominal pain, abdominal mass, and bloody stools. According to one source, these symptoms are present in fewer than 15% of children. Other symptoms might include screaming, irritability, lethargy, vomiting, diarrhea or constipation, fever, dehydration, and shock. This is a potentially life-threatening condition, so the nurse should be aware of these alternate presentations. Treatment includes an air enema or an ultrasound-guided hydrostatic saline enema. The patients may receive IV fluids, nasogastric decompression, and antibiotic therapy. Surgical intervention may become necessary if these procedures are not successful. Sometimes there's a spontaneous resolution. This occurs in about 10% of patients. Passage of a normal brown stool usually indicates that the intussusception has reduced itself. This should be reported to the practitioner immediately, abnormal rotation so that the plan of care can be around altered. The superior mesenteric artery during embryologic development. Volvulus is a twisting of the intestine around itself, thereby compromising blood supply to the intestines. These may cause necrosis, peritonitis, perforation, and death. Anorectal malformations are among the more common congenital malformations caused by abnormal development. Anorectal anomalies are classified according to gender and abnormal anatomic features. They can also be classified as high, intermediate, and low depending on location or level. Imperforate anus includes several forms of malformation without an obvious opening. There may be a perineal fistula, such as a cloaca in girls, a recto-urethroprostatic in boys, and a vestibular in girls. Malabsorption syndromes are characterized by chronic diarrhea and malabsorption of nutrients. They may result in failure to thrive. They may be classified as anatomic or biochemical defects. Celiac disease is also called gluten-sensitive enteropathy and celiac sprue. The four characteristics are steatorrhea, general malnutrition, abdominal distension, and secondary vitamin deficiencies. Celiac disease is characterized by villus atrophy in the small bowel. There's a genetic predisposition for this disorder. Diagnosis is based on a biopsy of the small intestine that demonstrates villus atrophy with hyperplasia. Also, after the individual eats adequate amounts of gluten and then gluten is withdrawn, a full clinical remission occurs. Treatment of patients with chronic celiac disease is primarily dietary and consists of strict adherence to a gluten-free diet. Wheat, rye, barley, and oats should be eliminated from the diet. Corn and rice become substitute grain foods. Short bowel syndrome, or SBS, is a malabsorptive disorder. It results from decreased mucosal surface area, usually as a result of small bowel resection. Examples of causes of SBS would include necrotizing enterocolitis and gastroesophageal. Therapy is focused on nutritional support through parenteral nutrition and enteral feeding. Ingestion of injurious agents. The most frequently ingested items are pharmaceuticals, cosmetics and personal care products, cleaning products, plants, toys, and miscellaneous substances. Parents should always be taught to call the Poison Control Center before initiating any intervention. Please refer to the emergency box on page 1304 about poisoning and box 41-19, which includes selected accidental poisonings in children. Heavy metal poisoning. A source for mercury poisoning would be mercury thermometers. Lead poisoning is the most common heavy metal poisoning. Sources for lead poisoning could be lead-based paints in older homes, soil that is contaminated with lead in the yard, cultural or ethnic traditions. Additional sources of lead are listed in your textbook on page 1309. It would be important to teach parents about primary prevention efforts. Universal screening has been recommended. Chelation therapy is the term used for removing lead from circulating blood and theoretically some lead from organs and tissues. Monitoring of renal function and blood counts during administration of chelation agents is essential. Most of the pathophysiologic effects of lead are reversible, but sometimes there are central nervous system consequences and permanent damage. Here is a diagram of how lead affects the hematologic, renal, and neurologic systems. Here's a question. What type of dehydration is defined as dehydration that occurs in conditions in which electrolyte and water deficits are present in approximately balanced proportion? A. Isotonic dehydration. B. Hypotonic dehydration. C. Hypertonic dehydration. And D. All types of dehydration in infants and small children. The correct answer is A.